does it affect at the end of the treatment that these patients receive?
Potentially it could, yes.
Okay, and what kind of treatment could that be?
Well, there's some biologic therapies. For example, if the patient has a mutation in the CTLA4 gene or the LRBA gene, abatacept could be utilized in those patients. If they have a PI3 kinase gain of function, we would use rapamycin in those patients more likely based upon published studies. Yeah, it depends. NSKB1 patients, if they have severe GI disease, they seem to be more responsive to TNF antagonism. So a TNF antagonist like infliximab might be useful in that patient. So in complicated patients, I think there is a place for it, and we do it fairly routinely.
Okay. So it's essentially you have, let's say, pragmatic reason to do that because you can adapt therapy. So it's not really for research purposes in this case.
That's
okay.
Well, yeah. It's not just for research. In these cases, we really are going to change therapy based upon it potentially.
Okay. And also, what kind of genetic testing do you use?
Most commonly, a genetic panel. That's the easiest to get a result and interpret. And in these panels that are now available, will find or will have all the genes that I'm speaking about, the ones that we know that there are, established precision therapies for. So that's the most routine thing that we do.
Okay.
We do that, yeah.
Okay. And do you happen to do also whole exome sequencing or not really?
Occasionally, but that's only for my research. So I have a research program for common variable immune deficiencies, and this is purely for research purposes. We will do that, and that's to try to identify genes, and it usually does not affect therapy. It would be more to try to understand the basic fundamental biology.
Okay, so this is really clear. And so and these panels, I imagine they are commercially available, so these are some kind of private players. And what kind of players are providing those in the U.S.?
We have found good success with insurance when you provide the justification and then you provide these manuscripts and publications. So commercial insurance will cover them. The company that we utilize does not charge anything additional for patients depending on their income potential. So if we have a patient that is a low-income patient, then whatever their insurance pays for, they'll accept that. And even if the insurance doesn't cover the entire amount of the test, they won't bill on top of that to the patient. And usually the most that comes out of pocket for the patient would be about $200. And so many patients are motivated to pay for that, even if there is this out-of-pocket expense.
Okay. And who exactly conducts the testing and the analysis? Are you doing it internally, or you have a dedicated laboratory or a company that does it?
Yeah, the company. The company that does the genetic tests will do the analysis.
Okay. And what companies are there that can provide this in the U.S.?
The ones that I use, and there may be more than this, but the ones that I use are called Invitae, INVITAE, or GeneDx. Those are the two that we use most routinely. Okay.
So these are, I imagine, private companies that already have established imprint in these panels for PID diagnosis. And okay, this is clear. Do you think there is some kind of unmet need in the diagnosis process for the genetic testing, or are you satisfied with the genetic panels and with the services that these companies provide?
Well, I think there's an unmet need in the patients that we don't find, the panel is negative. From there, it becomes much more complicated. Getting whole exome sequencing is expensive to do clinically. And it is hard to get good analysis of it. So that becomes, I think, that area from a clinical perspective would be an area of need, would be to improve the whole exome and potentially whole genome sequencing, making that more available and better analyzed for, to sort of reduce the cost and to make it more accessible.